about ready to wrap up. I just want to, Dr. Shi has rejoined us. I just want to maybe take care of a few final questions that were sort of placed by the attendees. I guess one, let's see, where should we go? Okay, we'll start here. I guess one question had to do, Angela, you used the term nuclear disarray in describing bile duct injury. How would you, maybe you could just elaborate on how you recognize that?
Sure. The short answer is that nuclear disarray is in the eye of the beholder. But if you are trying to kind of communicate exactly what we're looking for, we're talking about where nuclei are not evenly spaced. And so typically, if you look at your normal like just totally uninvolved bile duct, you'll see that the nuclei really do line up in a linear fashion. They don't overlap and there's no nuclear dropout. So there's no spaces where the nuclei are missing. And so nuclear disarray, honestly, is the weakest of the findings for morphologic evidence of biliary epithelial injury. But if you're finding that there's nuclear overlap or areas where there should be a nucleus, but there is not anymore a nucleus, then that is kind of the general findings of nuclear disarray.
Okay. Another question related to the cholestatic disorders talk, and I think you touched on this to some degree. Is there a pattern of fibrosis in vanishing bile duct syndrome that is recognizable?
Oh, that's a really good question. So in the cases of vanishing bile duct syndrome that I have seen, these patients actually have not progressed to fibrosis. They've actually just found a very bland bile duct loss. They have continual cholestasis, but otherwise, from what I have seen, these patients have not progressed. So in particular, the lamotrigine case that I referred to, we actually had a follow-up biopsy 2 years after the fact. She continued to be mildly cholestatic, both from the clinical setting and both on biopsy, but she did not have progressive duct loss and she did not have progression of that fibrosis. So, not in my understanding has it ever been described, but of course, never say never.
Okay, I guess we'll keep on. You got a lot of questions about bile duct disorders. I guess I'll keep on that theme. The next one is, how do you interpret neutrophils in and around ductular reaction, and do you for sort of the differential of infectious cholangitis, for example, do you want to see neutrophils sort of in the ductules, or how do you work through that?
Yeah, that's an excellent question. I think the answer is that there's histologic features that you can use to try to sway you one way or another, but there is nothing that beats clinical and cultures evidence to diagnose infection. So as you say, bile ductular reaction oftentimes is chemoattractant to neutrophils. So you commonly will see neutrophilic inflammatory infiltrate associated with that. I think when you are starting to see a lot of epithelial neutrophilic inflammation and possibly even neutrophilic kind of microabscesses within the lumens of those ducts, then that I think is when you might think a little bit more about an ascending cholangitis. But I think at the end of the day, ascending cholangitis is definitely a clinical diagnosis. And while we can suggest it, they really have to confirm it.
Okay, and then a final one. What etiologies in your experience commonly present as cholestatic hepatitis, where all three, I guess if Dan were here, he could answer this as well, as cholestatic hepatitis where all three enzymes, transaminases and alk phos, are elevated?
Oh, that's a really good question. I mean, I don't know that I'm going to have a complete answer for you right now. I think Dan might have been the better person to answer that. But what I would say is that I think anytime I see a complex picture like that, I actually oftentimes will think about drug. Because I think drug reactions can oftentimes be a little bit cholestatic and can be a little hepatitic, and they can have kind of components of both. I think the other thing to remember is that if you have an acute hepatitis pattern that is severe enough, a lot of those patients will become mildly cholestatic at some point in time. And so I think that, we've discussed these as if they're two separate entities. They're of course not. They're both associated with how the liver is functioning. So, I don't have a complete answer to that. I would say the drug is the first thing on my differential, but I think other than that, you have to always think that, in terms of how the liver is functioning, because the liver is just flat out not functioning well, you can always have a little bit of cholestasis just as a secondary process.
Okay, and let's see, a few questions for Lei. Question: how helpful is cytokeratin 19 immunohistochemistry to distinguish HCC and cholangiocarcinoma? I know you did touched on this a little bit, but maybe just elaborate on that point.
I think people do think CK19 is better than CK7, because for up to 30% of HCC would be positive for CK7, and some people argue the percentage will be lower for CK19. But we don't really use this a lot at Brigham. But this, again, I would think is not a very specific marker. But in difficult cases, when we are desperate, these would be something we could try. But I would estimate the percentage of false staining, like false positive staining, to be up to 20%.
Okay, great. And then another question related to your case 2, the adenoma. You did show an image or some images of these amorphous sort of fibrin granulomas as they were described. How do you explain the presence of those? Is that a mass effect, or why do you think they're there?
That's an excellent question. Granulomas can be seen in hepatocellular adenomas, and especially in the inflammatory type. I've seen multiple times of granulomas within the inflammatory adenomas, and not in the background liver. But this specific case, it is somewhat unusual. This tumor is actually HNF1 alpha mutated adenoma, so it was somewhat unexpected to see a highly nice granuloma in this. But I guess based on this case, granuloma itself probably is a non-specific finding. It just it reflects somewhat inflammatory status of the tumor itself. By itself, it doesn't really indicating the subtype of the adenoma, and also probably don't have any clinical significance as well.
Okay, and then I guess a final question, and this actually either of you could answer this. I'm not sure I know the answer to this, but I can guess. But I'm interested in what you think about how do you differentiate congenital hepatic fibrosis from advanced liver disease on biopsy, if you can.
I mean, I can give you like a vague answer from my perspective. I mean, I think congenital hepatic fibrosis oftentimes will have much more ectatic kind of biliary dilatation. I mean, we think about it more in the context of a ductal plate malformation. And so I think the morphology can be a little bit different, even if both have a kind of a fibrotic background. I think instead of the small caliber, irregular, jagged kind of ducts that you see in your typical ductal reaction, I would say that congenital hepatic fibrosis usually has a different morphology, a lot bigger, a lot more ectatic, just kind of almost more hamartomatous, if you will, because it's along the spectrum of a ductal plate malformation. But good question.
I completely agree with Angela's interpretation. Congenital hepatic fibrosis tend to have a component of ductal plate malformation. So in these cases, you tend to see anastomosing small ductules at the periphery of the portal tract, or see the feature suggestive of ductal, like the Weinberg complex. And also, I think want to clarify the concept that congenital hepatic fibrosis doesn't really have to be fibrotic or even or cirrhotic. This is still a process. You start with a disease with very little fibrosis and progress to the cirrhotic status. So it may not overlap with end-stage liver disease from other etiology.
Great. All right. Excellent. Well, thank you both. Those were some excellent questions, and hopefully we were able to get to nearly all of them.